Today I'm going to be discussing Eluvia in fempop disease. We're going to look at the data and I'll have a case presentation. I would just like to share, very proud to be here representing Newark Beth Israel as well as RWJ and being a part of this panel which is filled with excellence clinically and from a research standpoint, disclosures. So Eluvia is one of the best and the only drug-eluting vascular stent system that achieved FDA approval in September of 2018. It's built on the Innova stent platform, which was a self-expanding nitinol stent with a biostable polymer matrix. Obviously, paclitaxel is the biggest buzzword that's hit our community, but I believe that the data is very clear. I'm going to go through that today prior to my case. The Eluvia stent is delivered over an 035 wire. The coating design is really key here, which separates Eluvia from any other drug coating, if you will, or drug coated balloon. The primer layer promotes adhesion of the active layer to the stent. And the active layer is controlling a nice release of the paclitaxel, recognizing that we are at a concentration of 0.167 micrograms per millimeter squared, which creates it as the lowest dose delivered on the market. Polymer selection was very important as Boston Science evaluated multiple biostable and biodegradable polymers. And the ability to tune the drug over time in terms of its release and still have it unaffected during deployment made it exquisitely important using the Promise polymer, which has delivered long-term success in the coronary platform and now is delivering success in the peripheral state. We'll go over just two main trials quickly. The most significant being the Imperial Trial, which was a multi-center randomized controlled trial, 2-to-1, which was really revolutionary, and I think a lot of people were very surprised that a company was willing to go head-to-head with who was the mainstay in the market before they came out. Primary investigators was blessed to have Dr. Gray here presenting yesterday. We'll look at the study design. So there were three different arms. The randomized controlled trial, which looked at Eluvia straight versus Zilver PTX in a 2-to-1 randomized fashion. There was a long lesion sub-study, which I think is of significant importance because the majority of work that we do is not short. It's usually long length, if not full length, CTOs, et cetera. So the clinical results coming out of the Imperial Trial were significant with primary patency at 88.5%, and that was true over multiple subgroups, specifically the diabetics, the CTO subgroup, and the moderate to severe calcified lesions, 89% that were patent at 12 months. They're continuing to follow these patients out to 5 years. The Imperial Long Lesion Study, looking at that, 87.9% patency at 12 months, and with 50 stents having been delivered with an average stent length of 162 millimeters, which is probably more on par with what we're seeing clinically. Deaths are a very important issue, and certainly has been a part of the reason why we've been talking about this nonstop for the last 6 months. But as you see here, regardless of Eluvia versus Zilver PTX, there's no significant increase in death, either all-cause mortality or cardiac in nature, that would point to a specific issue with the stents. So in summary, the Imperial Global Randomized Controlled Trial showed primary non-inferiority effectiveness and safety endpoints were absolutely met. There was superior primary patency for Eluvia versus the Zilver PTX at 12 months, with a marked trend towards lower clinically driven target lesion revascularization rates and stent thrombosis rates for Eluvia versus Zilver PTX, about 50% lower for Eluvia, with a significant improvement in symptomatic, functional, and hemodynamic changes throughout the year in both groups. again, very important, Eluvia having half of the revascularization rate in comparison to Zilver PTX at 1 year. The next trial was the Majestic trial, multi-center with just a single arm looking at Eluvia, the 3-year follow-up of which is complete. The Kaplan-Meier curve here shows significant patency out to 24 months, looking at 85, and actually 36 months, sorry, 85% freedom from target lesion revascularization with no major amputations, and again, only 2 deaths at 365 days out, unrelated to the device or the procedure. And very important, no stent fractures, which is a major statement for this stent. When we're looking at the summary of the deaths, again, all-cause mortality was 3.6% in this trial, out to 3 years, and no significant target. So with that data in mind, present one complex calcified case, and yes, I do love alliteration, so apparently today's event is brought to you by the letter C, and that's only funny if you're a parent watching a lot of Sesame Street.
That was funny, for sure.
Thank you very much. It's okay to laugh, guys, come on. So we have a 75-year-old female. She's active. She had a left SFA stent placed in 2012, but presented back with increasing amounts of claudication. She's diabetic, hypertensive, and obese. Her exam showed palpable bilateral femorals with a Doppler distal left lower extremity. Taking a look here, we have our pulse waveform analysis showing on the left a significant loss of phasicity. I think that's a great way of saying it here, with a reduction in our ABI down to 0.83 on the left. And we have adequate flow up the legs. So an arterial duplex was performed, and just remember this, our velocity in the distal SFA was 322 centimeters per second, which is consistent with significant high-grade stenosis in the distal SFA. So this is angio taken. We have severe calcified stenosis noted at the distal SFA, just proximal to the adductor canal. See that just in a still frame here. In case you missed it, there's a nice green arrow for you. And another one. So rotablator was utilized for purposes of atherectomy and plaque debulking to improve our ability to A, balloon angioplasty, and B, to have successful intervention for this patient. You see a balloon angioplasty here on the right. We have our post-POBA, and then our picture here on the right is post-Eluvia placement in the mid to distal SFA. You know, I think it's always important. I agree with the earlier physician who said our outcomes are what we're really concerned about, wound healing in our CLI patients. And I think looking at a pretty angio is always great, but looking at the data post is of utmost importance, and recognizing have we really made a change in arterial flow in the long run. So being able to evaluate an ABI and a PVR in the distal left leg post and seeing significant improvement is obviously very satisfying, and I hope everyone's grinning a little bit on the inside. Going back to our ultrasound, looking at velocities, again, we were 322 centimeters a second in the distal SFA before this patient was treated, and post-stent placement, she's down to 112 centimeters per second and feeling much better. So I'll leave you with that. Any questions?